Morning, I'm Aaron Burnett, one of the emergency medicines here at Regents in the community group. And we're going to talk briefly about orthopedics in the community setting because it's much different than what we deal with in the tertiary care setting. And in one word, the main difference is residents. At Regents, we're fortunate enough to have orthopedic residents in-house 24/7. Much different in the community setting when you're dealing directly with an attending orthopedic surgeon who's trying to manage either an operating room schedule or a clinic schedule that day. The big overview is we're going to talk about when you need to consult orthopedics, the type of analgesic options that are available in the community, some tricks for when you're working with maybe a one doc, one nurse sort of environment, and then we'll spend a little bit of time talking about things specific to ankle fractures like bi and trimalleolar fractures. So the first question to know when you get into a community setting is who are your orthopedic consultants? There's often one, but sometimes two groups that you need to work with. Some of the key questions are, when does podiatry get involved? Do you have hand surgery coverage? And what sort of injury patterns are your community orthopedists not comfortable dealing with, and they'd prefer you to refer into a trauma center? There's some hard and fast rules which apply everywhere. I forgot to mention I brought Bill. He's one of my orthopedic colleagues out at St. Croix Orthopedics who's kind enough to join us today. He's just getting off call though, so he's a little bit sleepy. So the first question is, if you have a compartment syndrome or concern for compartment syndrome, that's always an appropriate consult. Whether or not your consultant is going to want you to obtain Stryker measurements can be an issue for you to discuss with them over the phone or preferably with the group ahead of time. Another question is open fractures. Those are almost always operative, although there are some changing strategies in terms of how quickly or emergently open fractures need to go to the operating room. And then whenever there's neurovascular compromise, those are typically patients that you're going to refer into a tertiary care center. Although if you ever have a question about whether or not a patient's appropriate for referral, the standard practice is to initially consult your local orthopedic providers. Analgesic options in the communities come down to two basic avenues: procedural sedation or regional anesthesia. Regional anesthesia can be very beneficial, especially when dealing with ankles, performing an ankle block, because it's much less resource intensive. You can usually get that ankle block in place much quicker than you can set up for a full procedural sedation. And if you're dealing in a one nurse, one doc sort of environment, propofol and other analgesics that we use for procedural sedation can be a little tricky. In terms of some tricks for when there's only a one nurse, one doc ER staffing sort of model, if you're going to do a procedural sedation, think about the agents you have available. Propofol is very nurse intensive and requires frequent titration of doses. That's opposed to something like ketamine, where you can give one large bolus dose and typically not need to give smaller incremental titrations. That frees the nurse up to be another pair of hands to help you, whether it's holding counter traction or wrapping with an ACE wrap. So consider the type of procedural sedation agent you're going to use and how that's going to affect your nursing colleagues and your nursing resources. Another thing that can be nice is to help the patient help you. So for shoulder reductions, one thing I found very helpful is to use soft restraints. Place the patient on their abdomen with their arm hanging over the bed. Put a soft restraint on their hand and then attach weights to that. You can leave them hanging in that for 15 minutes or so. And oftentimes, probably about 50%, I found that the patient will actually self-reduce just with that technique. If they don't reduce, you've at least fatigued the muscles by that point so that your attempt at reduction will go much smoother. Some specific things to the ankle. I think the most common fracture patterns we manage in the community are distal radius fractures, ankle fractures, and especially at Lakeview, we see a lot of artificial hip dislocations. So those are three pathologies I would encourage you to be comfortable managing independently before you leave residency. Specific to the ankle, bimal and trimal fracture dislocations, as you know, can come in horribly angulated. Some of the tricks I found dealing with these in the community is to do rapid reduction, which will help you to get better pain control. If you have procedural sedation capabilities, those are certainly nice, but being comfortable placing an ankle block to get good analgesia of this fracture pattern is also very useful. When you do immobilize patients, especially the angulated ankle fractures, I find plaster to be much more useful than orthoglass. One of the things on your first shift to do in your community ER is find out what splinting resources are available. There are some rural emergency departments that do not have long strips of plaster, the plaster rolls that we're most used to at Regents. So know whether plaster is an option for you, what type of padding they use, and make sure that your cast cart has things for splinting and not just casting, because I have come across carts that will just have true casting supplies, and we don't want to use those emergently. The next question is short versus long leg splint for ankle injuries. I almost always place a short leg splint, although again, this is something to discuss with your emergency medicine group and the orthopedics group you work with. There may be some groups who would prefer a long leg splint. However, again, in my experience in the East Metro and Western Wisconsin communities, short leg splints, the Robert Jones type via plaster are kind of the standard of care for ankle injuries. And then the last question is inpatient or outpatient management. The key goal of your reduction of these fractures is to align the bones, reduce the dislocation, and get near anatomic alignment. The mortise won't always be perfect, and that's not something that has to be achieved on your emergency department stay. If you reduce a dislocation, obtain near anatomic alignment of the fractures, have distal circulation sensation and motion after you are done reducing, and don't have concerns for compartment syndrome, those patients can typically be managed as an outpatient, although I would say it is certainly standard of care to discuss with your orthopedic colleague what you feel your post-reduction alignment is and your level of pain control in terms of whether or not this patient would be appropriate admission for pain control and urgent orthopedic consultation in the morning, or whether this is a patient who's appropriate for outpatient management with referral to orthopedic clinic later that week.